Okay, so in this video, chapter 22, we're going to talk about respiratory tract infections, neoplasms, and childhood respiratory disorders. So we'll start here with the upper respiratory viruses in adults. These include the common cold, which can also lead to rhinosinusitis, and influenza. Now, common cold is associated with a series of different viruses. It's not just one, but this is going to be one of the most common reasons for work leave in the United States. So you can imagine how abundant these are. And one of the most common respiratory viruses that cause the common cold is the rhinovirus. Now, these are going to really occur more in early fall and late spring, and mostly affect individuals between 5 and 40 years of age. Now, that differs from the parainfluenza and respiratory syncytial viruses because these are going to affect younger children, like less than 3, and then the corona and adenoviruses occur also in the winter and spring months. But these are all viruses that are associated with the common cold. Now, remember, if it's a virus, you can't treat this with an antibiotic. So really what we have then is just supportive therapy until the virus runs its course. Now, rhinosinusitis is going to be infection or allergy that obstructs sinus drainage. Now, this can be caused by viruses because these can cause so much inflammation that mucus starts to back up. But what's interesting, though, is that if you have backup of mucus here, it can put you at risk for bacterial infection, especially if you also have a limited airflow into the sinuses. It's going to put you at risk for anaerobic bacterial infection. But we can actually talk about this rhinosinusitis as basically being acute or chronic. Now, if it's acute, we say that there's facial pain due to swelling of these sinuses. We also have purulent nasal discharge because remember that all the paranasal sinuses drain into the nasal cavity, and they can also see a decrease in sense of smell because the olfactory epithelium is also near where the sinuses drain. And then fever because of the fact that inflammation will lead to the release of pyrogens, which can give you fever. Now, with chronic rhinosinusitis, what we'll see then is nasal obstruction, fullness in the ears, especially if this starts to back up through the eustachian tubes towards the middle ear. It can also lead to postnasal drip because of the fact that if your nasal cavity can't drain anteriorly through the nares here, it can drain posteriorly through the choanae towards your nasopharynx and the rest of your pharynx. Now, what's interesting too is this postnasal drip can lead to irritation of the pharynx as well as larynx. That can lead to hoarseness and chronic cough, as well as loss of taste and smell. And because this mucus and this discharge is going to have bacteria and dead cells, it can also lead to unpleasant breath and possibly even headache if there's enough swelling within the sinuses here. Now, what a surgeon can do then is actually go in and remove some of these turbinates, or at least make the opening wider. So if the meatal opening here is wider, these sinuses can drain more easily, and the individual is less likely to get recurrent sinus infections. Now, with influenza viruses, there's a wide variety of these. And in the U.S., approximately 36,000 people die each year of influenza-related illness. Now, it's transmitted by aerosol, which means it's airborne, and you need 3 or more particles to be infectious. But with an upper respiratory tract infection of influenza, it causes rhinotracheitis, which is like the common cold, but with more profound malaise because of a stronger immune response. It's going to lead to, just sort of weakness. Now, viral pneumonia is where influenza can go deep enough into the lungs to the point where it actually can, start to lead to pneumonia or swelling within deeper lung tissues. This can also lead to fever, tachypnea, tachycardia, cyanosis, and hypotension. Now, respiratory viral infection can be followed by bacterial infection because if there's enough inflammation and inhibition of your immune system, it could put you at risk for like an opportunistic bacterial infection. Now, if you look at the structure of an influenza virion, we see that it's a lipid bilayer, kind of like HIV, and we have glycoprotein spikes like HIV. However, the glycoprotein spikes on influenza are different, and we don't have a nucleocapsid like HIV. So instead of these, we have HA and NA, so hemagglutinin and neuraminidase. And this is what gives influenza its different names. If you guys remember, there was H1N1 that was going on a while ago. And what gives them the different numbers are the types of these glycoprotein spikes. And what allows the influenza virus to have different combinations of these, like H1N1 or H3N3, is the fact that its genome is segmented. And you can almost think of these as like chromosomes, where each one of these would be a little packet of genetic information. And the virus also packages its own RNA polymerase. Now, influenza is also, highly mutatable because of 2 things. We have genetic drift and genetic shift. Now, there's genetic drift because RNA polymerases that copy the influenza genome have a pretty high error rate, which means that this virus is going to be more prone to mutation. Mutation is change, and those changes could actually lead to the virus being able to evade your immune system if the epitopes of hemagglutinin or neuraminidase are different enough. It could look foreign to your immune system, and or at least maybe naive, and so that your immune system doesn't know how to recognize these new glycoprotein spikes if they're from mutation. Now that's genetic drift. That's going to occur more slowly. Now there's also genetic shift here, where influenza, if there are multiple virions infecting a host cell, they can swap out their chromosomes, because all these chromosomes are going to be hanging out inside of a host cell, and they're going to get shuffled just as a result of just the molecular world. And so what we'll find then is that let's say if you're infected with like H1N1 and H3N3, these can actually shuffle their chromosomes or their genomes here, and you might end up with different combinations like H1N3 or H3N1 or different combinations there. And so it's because their chromosomes are segmented, and that would lead to rapid change in the virus. And this is going to be genetic shift, and this can happen within the same host. This is why it's a challenge to target influenza, because of the fact that its chromosomes are separated, and you have this RNA polymerase which makes a lot of mutation. This is going to change from season to season, so it's difficult to make predictions about which strains are going to be going around. And the fact that it can mutate really rapidly means that it can evade your immune system if it mutates enough. So this question here says, for which viruses is a 2-year-old most at risk? Would it be the rhinoviruses, parainfluenza, respiratory syncytial, all the above, or just A and B? Well, we talked about that 2-year-olds are at a pretty high risk for things like parainfluenza and RSV. Now, slightly older children are at a higher risk for rhinoviral infections, but then children under the age of 3 are at risk for both parainfluenza and respiratory syncytial. So if we go back here, we find that respiratory syncytial and parainfluenza viruses are going to be more likely to infect this 2-year-old. So technically it would be B and C. I know this answers A and B here, but what we mean to say is actually parainfluenza and respiratory syncytial viruses are going to more commonly affect 2-year-olds. Now, rhinoviruses affect older individuals. Remember, we said that this was the most common cause of the common cold, and that's going to affect individuals between 5 and 40 more frequently than a 2-year-old. So, in terms of pneumonia, we think about this as being inflammation of the alveoli and bronchioles. Now, with typical pneumonia, there's bacteria in the alveoli, and if it affects alveoli of a particular lobe, we call it lobar, or if it affects distribution over more than one lobe, we call that bronchopneumonia. Now, atypical pneumonia is either viral or mycoplasma, and these are going to be infections of the alveolar septum or the interstitium. So we're saying that these have actually gone into the tissue itself, and they're more disseminated throughout the lung tissue, just not being in the space of the lung itself. And that would be more associated with atypical pneumonia. Now, if you can compare viral versus atypical pneumonia, typical versus atypical pneumonia, we find that typical pneumonia is going to cause, a lot of mucus production within the alveolar spaces because of macrophage and leukocyte infiltration. So the bacteria will invade and usually just remain in the alveoli with typical pneumonia. So it's going to be associated with a lot of productive cough and a lot of sputum, and as well as a decrease in airflow because of the fact that these airways are plugged with a lot of mucus. Now, with atypical pneumonia, these microorganisms like mycoplasma and different viruses are more likely to infect the alveolar septum, so the space between alveoli, or deeper lung tissue like the interstitium, or in the tissue of the lung itself. And so you find that this would lead to more inflammation within the lung tissue, not necessarily as much inflammation along the airways. But because of inflammation inside of the tissue itself, it can actually start to impinge on the airway diameter, which can also limit airflow. Now, with atypical pneumonia, you're going to see less of a productive type of sputum response because the infection is more localized to the inside of the lung tissue itself. However, there will be some mucus production that can lead to a minor productive cough. Now, with tuberculosis, we find that this is actually the world's foremost cause of death from a single infectious agent. And this is right next to things like malaria. Now, it actually leads to 26% of avoidable deaths in developing countries. And so it's still a pretty rampant problem worldwide, mostly because of the fact that there are a lot of drug-resistant forms now. Tuberculosis antibiotics have gotten cheap enough over the years to how we could treat this pretty easily and cheaply, even in the developing world. But the problem now, though, is that these antibiotics that we use to fight tuberculosis have been around for a while, and because this is a microorganism, it evolves, and like all living things, they change or evolve. Now it's actually resistant to some of our, actually all of our major classes of antibiotics against tuberculosis. So we actually have quadruply resistant mycobacteria now, which means they're resistant to all 4 main classes of antibiotics against it. Now, Mycobacterium tuberculosis hominis is the most common strain that's more likely to infect humans, hence the hominis. Now, this microbe is aerobic, so it's oxygen requiring. It does have some invasive factors like a protective waxy capsule, and this actually evades phagocytosis so that it can actually live within a phagolysosome of a macrophage because of this waxy capsule. And because of this, it can stay alive in suspended animation for years. If it can live within a phagolysosome of macrophage, it's not going anywhere. In fact, it's pretty difficult to remove once you have an active infection of tuberculosis. Now, initially with the infection, it's going to be spread through respiratory droplets. And macrophages begin a cell-mediated response. So this is part of your innate immune response. This is in the first several hours of exposure before you can even have kind of like a adaptive immune response. Macrophages start to engulf tuberculosis microbes, and they try to break these down into phagolysosomes, but because of that waxy capsule, TB can live within a phagolysosome of a macrophage, and it can take 3 to 6 weeks to develop a positive TB test. Now, this ultimately results in this granulomatous lesion called a Ghon focus, and we have the cell-mediated hypersensitivity response that leads to the inflammation of that local area of tissue, and we get this Ghon complex. Now, the Ghon focus or Ghon complex is basically just a little local area of lung tissue that has macrophages, T cells, and some inactive TB. And these macrophages and T cells have begun to surround TB and sort of encase it within a local area. And the problem with these Ghon focus, though, is that it's not stabilized with collagen fibers, which means it's more loose. So that the Ghon complex is more likely to break apart, and it can lead to progressive disseminated tuberculosis, which basically can spread to lots of different organ systems. One of the places that TB likes to also invade are bones, especially the vertebrae of your thoracic region, because it's right by the lungs. You can actually get an interosseous infection of TB, especially in those vertebrae there. Now, if the Ghon complex has been around for a while, what's really interesting then is that you can start to wall it off within this healed dormant lesion. Now, in a dormant lesion, we're talking about now this caseous necrosis that's surrounded by a fibrous capsule. And if someone has this healed dormant lesion, they can live with this for the rest of their life. And it may or may not reactivate. Now, sometimes this can reactivate, which can disseminate to other organs. And we'd call this reinfection or secondary tuberculosis. But secondary tuberculosis is going to be after that initial exposure, and it's a reactivation from either a Ghon complex or this healed dormant lesion, or from other organs too. Like, it doesn't have to hang out in the lungs. It also can live within your liver and pancreas and other organs. So this Ghon complex, we said there are nodules in lung tissue and lymph nodes. You can see that here. Now it's caseous necrosis inside, but because the Ghon complex or focus here is fairly new, you don't find a thick fibrous capsule around it, which means that TB bacterium are more able to spread out of this lesion into surrounding tissue and cause problems nearby. Now, calcium may deposit in the fatty area of necrosis, which makes it harder and also more stable. And what's interesting too is this is visible in x-rays. So one of the confirmatory ways you can diagnose a latent or active TB infection is to take a chest x-ray. It'll see it on the x-ray as kind of an opacity within the lung region. Now, this discussion here says someone in your class has positive TB test. What does this mean, and are you at risk for infection? Well, with a TB test, all you're essentially doing is injecting an individual with epitope of TB. And so if you've been exposed to TB before, or if you have a latent infection, that means you're going to have an adaptive immune response to that epitope, and if you're going to have a positive TB test. So having a positive TB test doesn't mean that you have an active infection or even latent infection, but it does mean that you've been exposed at some point in the past, or you're very hypersensitive to that particular epitope. Now, if you're around somebody who has a positive TB test, you're not necessarily at a risk for infection because it doesn't mean they necessarily have active TB. It might be latent, which means there might not be bacteria, spreading and proliferating and, capable of actually infecting somebody else. Or it just might be that they don't even have an infection and they've just been exposed at some point in the past. Now with primary TB, we talk about how it's going to be isolated within Ghon foci, and that they're not contagious as long as they're within this Ghon foci, and they're inactive because remember, Mycobacterium tuberculosis is aerobic, and usually the center of these Ghon foci is anaerobic because it's just an area of necrosis and there's no blood vessels in there, which means they're inactive and not contagious. Now, if someone's immune response is inadequate, these bacteria can multiply in the lungs, which can lead to progressive primary TB, and so that they never actually get placed in Ghon foci, and instead they're capable of just spreading all throughout the lung tissue, but that's if their immune response is inadequate, like with AIDS. Now, with miliary TB, we find that these lesions look like grains of millet in the tissues, and now what's really interesting then is that this is more commonly associated with the food supply. So now the USDA can inspect meat, and we have pasteurization of milk, and it keeps tuberculosis out of our food. That's true in the US, but not necessarily true worldwide. Now, progressive primary TB can be caused by miliary TB, and there's signs of pneumonia. You find bacteria in the sputum, and therefore is infectious there. And these bacteria may erode blood vessels and spread throughout the body. Now, when they spread throughout the body, you're talking about they're going to go into bone and other organ systems like your liver and pancreas. And the secondary TB is a reinfection from latent bacteria that were already in your body. So the reactivation from previously healed primary lesion, like a Ghon focus or some caseous necrosis in the lung, and these bacteria can damage tissue in the airway, causing cavities. Now, if it's chronic secondary TB, you get these large cavities that can occur within the lung tissue because of destruction of the lung tissue. And we see signs of chronic pneumonia, like gradual destruction of your lung tissue and these large cavitations. And then consumption is a word we use to describe how someone basically just wastes away if they have untreated secondary TB, where essentially they have respiratory failure, they are anorexic from the inflammation, and there's just a slow wasting of their bodies until their bodies are consumed, and this can take years. So it's like a slow, painful death. Now this question here says, which type of TB may be reactivated if the patient becomes immunocompromised? Well, this would be more associated with secondary, right? Like if you were immunocompromised, it would make sense then that an already latent TB within your lung tissue or other organs could reactivate and cause problems as a result of being immunocompromised. So cavitary tuberculosis is one of the consequences of chronic pneumonia, and what we find then is destruction of the alveolar septa, such that instead of getting these nice distinct regions of air-filled sacs, you have these large cavities where inflammation has destroyed large areas of lung tissue. Now, obviously, this is going to lead to pulmonary dysfunction, and that's going to be associated with that consumption or wasting we talked about. But this is going to be from active TB, not latent. So if it's latent, it won't cause this cavity. Latent TB is going to be stuck in a Ghon focus, which is basically a little caseous necrosis somewhere in the lung tissue. Now, with the different types of lung cancer, we have bronchogenic carcinoma. And remember, lung cancers are essentially just, they're cells that are metastasizing, and they can either be from the lung tissue itself or from other tissues. So a lot of lung cancers don't come from the lung itself. They're not a primary lung cancer. Some lung cancers come from the skin, where it could be like an epithelial cell of your skin that's spread to the lungs. like melanoma can reach the lungs. They can also come from, like the digestive tract. So they don't always arise from the epithelium of your lung tissue, but they can. In fact, when we talk about the small cell lung cancers, these are the ones that typically don't arise from the lung tissue itself. These small cell lung cancers are highly metastatic, very poorly differentiated, and they divide extremely rapidly. Now, these typically don't start in the lung tissue, though. They're usually going to start in another area, like the skin, liver, or your digestive system. And these can spread to the lung from those organs. Now, non-small cell lung cancers include things like large cell carcinomas, squamous cell carcinomas, and adenocarcinomas. Now, the adenocarcinomas are a tumor of the glandular epithelium, and these are going to be more associated with the distal areas of your lung. So you're going to find adenocarcinomas, at the outer periphery. Now, these are pretty slow growing and, less likely to metastasize. But that differs from, like, let's say the large cell carcinomas, which are more fast growing and more likely to metastasize. Now, squamous cell carcinomas arise from the bronchial epithelium, and these are intermediate growth, and they can also metastasize. But you're going to find these more like at the hilus, like near the larger bronchi, like your main bronchi and secondary bronchi. You're going to see squamous cell carcinomas. So if you have someone taking a chest X-ray because you suspect lung cancer, and you find that the growth seems to be at the periphery, it's more likely to be an adenocarcinoma. If it's closer to the hilus, it's a squamous cell carcinoma, and then large cell carcinoma would require more like tissue biopsy to really be definitive here. Now, with the adenocarcinoma of your lung, this is associated with smoking, but you can see that here, the anthracosis and tarring of lung tissue. But you can see that there's this area where it looks more pink, and you might think, oh, this is a little area of healthy tissue because it looks so pink and this is so dark. Well, the reason why this is pink is this is new growth. This is old lung tissue. This is new growth. So this is going to be the cancer itself that's spreading in the outer edge of the lung tissue. And this is actually a tumor of the glandular epithelium near the smaller airways. That's why it's out by the periphery. Now, these are fairly slow growing, and they could be, monitored and maintained, even just with, a minor amount of chemotherapy and maybe some radiation. And depending on the age of the individual, it might not even be worth treating if they're already fairly old. Now, in terms of manifestations of lung cancer, it can come about in a variety of ways. You might see changes in organ function, like damage, inflammation, or failure. And this could be due to the fact that the lung cancer itself is, causing compression of a local area of lung, like an entire lobe, or maybe even an entire lung itself. Now, some of the local effects of tumors could be compression of nerves, veins, possibly even GI obstruction. In fact, what's interesting is that your esophagus is located right by the lungs, just posterior to the heart. And so sometimes what can happen is if it's, let's say, like a squamous cell carcinoma of the lungs, which is by the hilus, that tumor can start to impinge on the esophagus. Or if it's by the base of the left lung, that can start to kind of push down towards the stomach. And so it can lead to GI obstructions. Now, sometimes we also talked about this in previous chapters, but we talked about how sometimes lung cancers, as a consequence of their poorly differentiated nature, they can also release ectopic hormones. Like you can find then, we call these paraneoplastic disorders, because sometimes lung cancer cells can release hormones like parathyroid hormone. So you might see things like hypercalcemia associated with lung tumors. And there are also non-specific signs of tissue breakdown like protein wasting and bone breakdown as well. So in terms of respiratory distress syndrome, this is actually going to be a childhood disorder. So moving on from lung cancers. Now, respiratory distress syndrome comes from a lack of pulmonary surfactant. And we talked about how pulmonary surfactant helps to decrease the cohesiveness or stickiness of water by breaking surface tension and interfering with hydrogen bondings. Now, we've also talked about how surfactant, prevents alveoli from sticking together. But if you lack surfactant, infants aren't strong enough to inflate their alveoli, so the alveoli stay stuck together. Protein-rich fluid leaks into the alveoli and further blocks oxygen uptake when they're collapsed there. And so then these individuals then have respiratory distress because at birth, they don't have strong respiratory muscles to try to fight these sticky alveoli. So this is more common in premature births. And the reason why it's more common in premature births is that they're not ready to make surfactant yet. And so with this decrease in surfactant and the fact you have immature lung structures, there's a decrease in lung compliance. And this decrease in lung compliance comes from the fact that the lung is partially collapsed. That's why it's atelectasis. And it's partially collapsed because it's internally sticky from surfactant. That can lead to hypoxia, which can lead to things like pulmonary vascular constriction, pulmonary hypertension, and a decrease in pulmonary perfusion. Now, it can also lead to increased pulmonary capillary permeability from that hypertension. This is why you get movement of fluid into the alveoli, causing this hyaline membrane formation, and that further blocks the airways. Now, the treatment for this is mechanical ventilation, which just forces their airways open. And there are also different drugs that act to increase the amount of surfactant you can produce. But you can also do, big lung lavages, where they essentially can wash out the lung tissue with these rinses that help to introduce surfactant and clear out any kind of sticky mucus from the airways. This question here says true or false. Premature infants are at a greater risk of developing respiratory distress syndrome, RDS, than term infants. And that's true. We talked about how respiratory distress syndrome, also called IRDS, infant respiratory distress syndrome, is due to lack of pulmonary surfactant, but this is as a consequence of their premature birth. And the type 2 cells of their alveoli aren't ready to make surfactant, and so you're more likely to see this in premature births because at 40 to 42 weeks, then they're more likely to be able to ready to make surfactant. But before week 28, they're much less likely to make surfactant. So in terms of respiratory obstruction in children, we find that it's going to cause an increase in airway resistance, right? So you get a decrease in airflow. Now, we have extra and intrathoracic airways, and the extrathoracic airways are upper airways. So if someone has an increase in resistance of extrathoracic or upper airways, we're going to see things like prolonged inspiration as well as inspirational stridor. Stridor is kind of like a choppiness sound. And inspiration retractions can occur as the ribs are moved outward and the body wall doesn't expand with the rib cage. So this is kind of interesting effect. Let's say if you go to try to breathe inward, to inhale, and your thoracic cage should expand. It turns out that we see that the rib cage doesn't expand as it should, and this is due to that decrease in airflow and increase in resistance near the beginning of the respiratory tract. So they're going to have quite a bit of a vacuum inside their lungs, which prevents their lungs from expanding. Now, intrathoracic airways or lower airways, if these are obstructed in children, can lead to things like prolonged expiration, so it takes much longer to exhale, as well as wheezing. And you're going to see rib cage retractions as the ribs are pulled inward, but the air doesn't leave the lungs. And so this is actually going to be due to a decrease in airflow from the lungs itself. Now, obstructive disorders can include things like croup and epiglottitis if it includes an upper airway. And your lower airways would be like bronchiolitis, which is basically just inflammation of the bronchioles all over. So with croup and epiglottitis, these are going to affect upper airways. And we said that croup is more of a larynx problem. And epiglottitis affects the epiglottis or part of the larynx. Now with epiglottitis, it can lead to like a barking cough. And it's going to be a subtype of croup. And croup is going to be, inflammation of the larynx. So again, they're going to see like a barking cough with stridor. And they're actually associated with what we call croup cough, where it sounds like kind of an odd sort of barking noise that it's especially common in children. Now with the lower airway, this is associated with things like bronchiolitis, which is inflammation of the bronchioles. And so just generally you're going to see a constriction of these airways from that inflammation and a decrease in airflow to the distal airways as a result. And this question here says true or false, epiglottitis can cause stridor. And the answer is true. We said that epiglottitis affects the upper airway like croup does. And so when the child goes to breathe inward or inspire, it's difficult to pass through air through this narrowed airway, and it causes this noisy inspiration or stridor noise. It's hard to describe without just hearing it, but if you Google stridor, there's lots of audio clips out there that can play it for you.